So if you break your arm, an X-ray gives the surgeon this like perfect glowing map to fix it,
Right,
right?
yeah. You see that jagged white line on the screen and you know exactly what to do.
Exactly. The doctor points to it and the path forward is perfectly clear. But what happens when a surgeon has to rebuild highly vascular tissue that's just totally invisible to an X-ray?
Well, you're stepping into a landscape where doctors are basically flying entirely blind.
Yeah.
I mean, you are navigating exclusively by topographical knowledge and, well, tactile feel. It's a completely different paradigm of medicine.
And that is exactly our mission for you today. Welcome to another deep dive.
Glad to be here. We've got a lot to cover.
We really do. We are unpacking a massive stack of highly specialized sources today, clinical texts, plastic surgery journals, dermatological guidelines.
Right, and our core focus is incredibly specific, but it has these huge implications for how we understand the human body.
Exactly. We're looking at how a surgeon's technique has to radically adapt when reconstructing the labia majora.
Specifically, how the trajectory and the depth of an instrument, a microcannula, has to change.
Right, like how it changes when treating a patient with thin, crinkled skin versus someone with a deep, hollowed labial fat pad.
Because to the untrained eye, or even if the patient just looking in the mirror, these two issues often just look like general aging.
Just a sort of general sense of deflation.
Exactly, deflation. But treating them requires navigating two entirely different topographies within like the exact same square inch of the body.
Okay, so let's unpack this. To really understand the mechanics here, the sources suggest we first have to look at the labia majora as basically a functional analog to the human face.
Right, which is a great way to think about it.
Yeah, because just like the face, this area suffers from two distinct problems as we age or, after menopause or after major weight loss.
You get volume loss, which causes that deep deflation.
Right.
And then you have collagen loss, which causes the surface crinkling.
And this isn't just about aesthetics, right? I mean, both of these lead to severe functional discomfort.
Oh, absolutely. And before we even talk about how the surgical tool moves, you really have to understand the tissue it's moving through.
A canvas, basically.
Right. So the first major issue detailed in the clinical texts is called lipoatrophy.
Which is essentially just the melting away of the deep fat pad over time, right?
Exactly. And when this deep fat pad hollows out, the labia majora loses its core structural volume.
And so it loses its protective function.
Yes. The immediate result is that the inner structures, like the labia minora and the clitoral hood, they end up protruding.
Just because the outer envelope that used to shield them is gone.
It deflated, yeah.
And reading through these journals, there is a huge diagnostic trap here, right?
Oh, a massive one.
Because patients come into a clinic complaining that their labia minora suddenly stick out too much. They're getting chafing during exercise or discomfort in clothing, and they ask the surgeon for a reduction.
Right, they want a reduction of the inner tissue. But the minora didn't actually grow.
Right, they didn't change at all.
Exactly. The majora just shrank away and unveiled them.
Wow.
This is incredibly common, and it's frequently misdiagnosed as minora excess.
Which is wild. So if a surgeon just reduces the minora in that scenario, they're, what, overcorrecting a structure that wasn't even the root problem?
Right, and they're potentially removing sensitive tissue totally unnecessarily. The real solution is rebuilding that protective outer wall.
Okay, so at the exact same time that the deep fat is melting away, the superficial dermis, the skin layer right on top, is also degrading.
Yes, it's losing its elasticity and its collagen matrix.
Which creates that deflated, wrinkled appearance on the very surface. I sort of like to think of this whole anatomical area like a luxury mattress.
Okay, mattress, I like that.
Yeah, like the deep fat pad is the internal structural springs, providing the shape and support, and the superficial skin is the quilted pillow top.
That analogy holds up perfectly, mechanically speaking.
Okay, good.
Because you have a profound structural failure underneath and the textural failure on the surface.
But hold on, I have to push back here. If the whole area, the springs and the pillow top, is deflating and sagging, why can't a surgeon just, plunge a syringe into the middle of the tissue and pump one huge volume of filler in?
Like just inflate it all at once.
Yeah, just inflate both the deep structure and the surface at the exact same time, like blowing up a balloon.
Well, what's fascinating here is that doing that just creates a shapeless, distorted mass.
Oh, really?
Yeah, you aren't rebuilding the intricate structures. You're just creating a bulge.
Ah.
The deep fat pad and the superficial subcutaneous tissue. They are two distinct anatomical layers.
And crucially, they're separated by fascia, right?
Exactly. Fascia is this tough, fibrous tissue. Think of it almost like a layer of biological saran wrap that divides the different compartments of the body.
So you can't just blast filler through it and expect a good result.
No, not at all. You have to purposefully bypass that fascia to fix the springs
Huh.
and then purposefully stay above it to smooth the pillow top.
Which brings us to the actual instrument required for this kind of precision.
The microcannula.
Right. Because a single deep injection won't work, the surgeon needs a tool capable of navigating these distinct layers horizontally, right? Sliding through the tissue without destroying everything in its path.
Right, and the microcannula changes the entire safety profile of the procedure.
Because traditional hypodermic needles are sharp, they're designed to penetrate vertically.
Exactly, they cut through multiple tissue layers, slicing through whatever's in their path.
Which sounds terrifying in this area.
It is. When you're working in a highly vascular area like the vulva, slicing vertically through tissue with a sharp blade means you're risking vascular occlusion.
Which is literally injecting filler directly into a blood vessel.
Exactly.
And vascular occlusion is the absolute nightmare scenario in aesthetic medicine, right? Because if you block that blood flow, the tissue downstream basically starts to die.
It does. It's a medical emergency.
But I was reading something in the stack about needles actually causing the filler to migrate to the completely wrong place too, even if you don't hit a vein.
Yes. The sources cite fluoroscopic imaging studies to track exactly this.
Fluoroscopy is basically real-time X-ray video.
Right. And when they tracked needle injections under fluoroscopy, they found that the sharp needle actually causes filler to migrate along the needle track.
Into unintended superficial layers.
Yes, roughly 60% of the time.
60%. Wow.
The sharp blade creates a channel, and the pressure just forces the gel back up that channel into the wrong plane.
But a cannula is fundamentally different. It's a flexible, completely blunt-tipped tube.
Right, so instead of cutting through tissue, it slides between the tissue planes.
And the safety data on this is just wild.
It really is. The Alamed All data from 2021 is the gold standard here. They looked at over 1.7 million syringe injections.
Okay, that's a massive sample size.
Huge. And they found that blunt cannulas are associated with a 77.1% lower odds of vascular occlusion compared to needles.
Just because the tip is rounded and blunt, so it actually pushes blood vessels out of the way instead of slicing into them. But here's where it gets really interesting for me, mechanically speaking. And honestly, it took me a second to wrap my head around the physics of it.
Oh.
Yeah, because if the cannula is completely blunt, like the end of a ballpoint pen, how does it actually break through the patient's skin to get inside the tissue in the first place?
Well, it doesn't. A blunt cannula cannot pierce intact skin.
So what do they do?
The surgeon has to use a traditional sharp needle first to create what is known as a pilot hole.
Oh, okay.
They make a tiny single entry point with a sharp needle, they withdraw the needle entirely, and then they thread the blunt cannula through that exact same hole.
It's basically like pre-drilling a tiny hole in a piece of drywall before you push the actual anchor in.
It is the exact same mechanical principle, yeah.
That makes so much sense.
And the benefit of this is that once the cannula is inside, because it's so long and flexible, it can achieve a much wider horizontal spread under the skin.
The data we have here shows that cannulas achieve an even spread of 25.6 millimeters in the tissue.
Right? Versus just 13.5 millimeters for a sharp needle.
So you can treat a massive area from just one single pilot hole, rather than poking the patient a dozen times.
Exactly. And fewer entry points means significantly less physical trauma.
And vastly reduced bruising, I imagine.
Absolutely. Which means a much faster, more comfortable recovery for the patient.
Okay, so we've managed to snake this blunt tube safely through a single pilot hole without slicing a vein.
Right.
But getting in is only half the battle. How does the surgeon actually know where to deposit the filler when they are completely blind?
Well, let's start deep. We are rebuilding the hollowed-out fat pad first. We're fixing those internal mattress springs.
Right.
This requires a highly systematized approach. The texts outline a specific protocol called the vulvar anatomical vector technique.
So to fix the deep hollow and achieve coaptation, which is just the medical term for restoring the volume so that two sides close the gap and protect the inner structures again.
Right. To do that, the cannula targets 3 specific deep vectors.
Yeah.
VA1, VA2, and VA3.
And to give you a mental map of what those vectors are, think of VA1, 2, and 3 as the deep foundation pillars, like the wooden studs inside a wall.
That's a perfect way to visualize it. They're the core structural supports.
And the physical mechanics of how they build these pillars are so precise. The surgeon typically takes a 22-gauge, 70-millimeter long cannula, right?
Yes. They insert it at the very upper limit of the labia majora. Then, The trajectory runs deep, deep down into the fat pad.
Using what the sources call a retrograde technique.
Right. Retrograde means they push the blunt tube all the way in to the furthest point of the targeted vector.
Okay.
Then, as they slowly and steadily pull the cannula backward out toward the pilot hole, they're simultaneously laying down small structural boluses of filler in its wake.
Usually about 1.0 to 2.0 milliliters of cross-linked hyaluronic acid filler.
Exactly. Or, if they're utilizing the patient's own fat for a fat transfer, they might use a thicker 14-gauge cannula passed upward from the bottom. But the retrograde principle is exactly the same.
So they're essentially laying down train tracks of product in the deep fat pad.
Right, to recreate that structural support that melted away over the years.
But wait, if a surgeon is burying a 70-millimeter tube deep under the skin, completely out of sight, how in the world do they avoid hitting major blood vessels?
It's tricky.
I mean, the pudendal arteries and the vestibular bulbs are right there in that anatomy. 1 millimeter in the wrong direction, and you are in a massive danger zone.
This is where the sheer artistry of the blunt cannula comes into play. It relies entirely on a concept called tactile feedback.
Tactile feedback?
Yeah. Because the cannula is blunt, it doesn't just silently slice through whatever's in front of it.
Right, like a needle would.
Exactly. When an experienced injector pushes it through the tissue, they can literally feel the varying resistance of the different biological structures.
Oh, wow.
That vibration and resistance travels up the long metal shaft of the instrument directly into their fingers.
So they can physically feel if they hit something solid versus something soft just through the metal.
They map the invisible anatomy entirely by touch.
That is wild.
They can feel the distinct, mushy lack of resistance in soft fat. They can feel the tough, scratching resistance of a fibrous fascial band.
And the blood vessels.
They can feel the rubbery, bouncy resistance of a blood vessel. A sharp needle would just slice straight through the wall of that blood vessel before the surgeon even realized they were near it.
But the blunt cannula doesn't.
Right, the blunt cannula meets the vessel wall, it bounces, the surgeon feels that specific rubbery resistance, and they can gently pivot the tip of the tube to glide safely right past the hazard.
That's incredible. It's literal echolocation, but through physical touch.
It really is.
Okay, so we've laid down these deep retrograde pillars of filler. We've rebuilt the deep fat pad, restored the volume, and achieved coaptation.
Right, so the inner structures are safely protected again.
The springs of the mattress are fixed.
Exactly.
But we still have the crinkled, deflated skin on the surface.
The pillow top is still a mess.
Yeah. So what happens now?
Well, this is where the entire mechanical approach has to pivot.
Right.
If you use the same deep technique on the surface, you will ruin the result.
Okay, so with the deep structural volume restored, the focus shifts entirely to the surface layer.
Right, the superficial subcutaneous tissue, or SST.
And the vectors change, right? From those deep foundation studs to what the protocol calls VAS.
Which covers the entire broad surface, yes.
Yeah.
And VA4, which angles toward the mons pubis.
So if we go back to the wall analogy, think of these superficial vectors as the exterior paint job that covers the entire wall.
Exactly. And the movement of the tool changes completely to match that.
Right. Instead of going deep and laying down those thick retrograde pillars, the cannula is brought right up, just barely under the surface of the skin.
Yes. And the surgeon changes from a linear motion to a superficial fanning technique.
Fanning?
Yeah, they pivot the long cannula back and forth from the exact same single pilot hole, like a windshield wiper. They fan it back and forth to lay down a millimeter-thin sheet of filler right beneath the skin, spreading a much smaller amount, typically just 0.5 to 1.0 milliliters across a wide surface area.
And crucially, the sources note they aren't using the same filler for this part either.
Definitely not.
Because deep down, you need a firm, highly cross-linked structural filler. And cross-linked basically just means the molecules are tightly bound together so they don't break down easily, right?
Yeah. It creates a very firm gel with a high G prime. High G prime just means it's firm, like biological mortar.
But on the surface, to smooth out crinkled skin, you can't use mortar.
Right, you'd feel it. You need a much softer, lower G prime filler that spreads more like a thin, hydrating lotion.
You need it to integrate seamlessly into the thin tissue to smooth the crinkles, not create rigid bumps.
Exactly.
Now, making a connection to some of the other dermatological texts in our stack today, I have a big question about this superficial fanning technique.
Okay, what's that?
Well, the sources explicitly mention that if you put hyaluronic acid filler too close to the surface in thin skin-like under your eyes, for example, the light actually scatters through the clear gel under the skin, and you get this, like, blue-gray, bruises-looking tint?
Ah, yes, the Tyndall effect.
Right, the Tyndall effect. So if the skin on the deflated labia majora is incredibly thin and crinkled, isn't dragging a cannula in a superficial fanning trajectory incredibly risky for causing that Tyndall effect?
Well, you've hit on the exact reason why this specific procedure requires such immense technical skill.
Because it's so risky.
Right, it's why mastering the cannula is so difficult. The Tyndall effect is a massive risk when you're working just below the dermis.
So how do they navigate that risk? How do they avoid turning the tissue blue?
This is exactly why the trajectory, the volume, and the chemical type of filler must adapt so radically when the surgeon moves from the deep fat to the surface skin.
So they're relying heavily on that soft filler.
Yes, but mechanically, the surgeon basically has to walk a microscopic tightrope. They must use that highly specific, low-viscosity, spreadable filler we just talked about, and they have to keep the cannula moving constantly in precise, tiny micro-aliquots.
An aliquot is just a very small, measured fraction of the liquid, right?
Right. They're laying down these microscopic fractions while fanning. If the surgeon accidentally dips their hand too deep while fanning, they waste the soft filler in the deep fat pad, where it provides absolutely no structural support.
And if they go too high...
If they push too hard upward against the surface of the skin, they risk the Tyndall effect, or they risk creating visible, lumpy contour irregularities.
Because they're operating in a tissue plane that is fractions of a millimeter thick.
Fractions of a millimeter, exactly.
So if you're listening to this and wondering why this level of micro detail matters to you, let's bring it all together.
It's all about the mechanics.
Right. The difference between treating a deep anatomical hollow and treating superficial crinkled skin isn't just about grabbing a different syringe off the tray.
No, it requires a radical physical shift in how the instrument is wielded within the human body.
You're going from deep, structural, retrograde pillars designed to push tissues apart and rebuild core volume,
Right.
to superficial, sweeping, delicate fans designed to lay down a microscopic sheet of hydration just beneath the dermis.
And whether you're evaluating a reconstructive or aesthetic procedure like this for yourself, or, you're simply fascinated by the sheer mechanical ingenuity of modern medicine, understand this layered approach is just vital.
It really is. Knowing the why behind the how empowers the patient.
Absolutely. It demystifies the human body, transforming it from this mysterious source of anxiety into a marvel of anatomical engineering that can actually be mapped and repaired.
And that actually leads me to a final thought for you to chew on today. We've just spent all this time talking about how a simple, blunt metal tube can be guided with such unbelievable tactile precision through dual tissue planes.
Right, to restore both deep structure and superficial surface.
Exactly. So if we can map and rebuild the intricate, invisible architecture of the labia majora using just tactile feedback, how might these exact same multiplanar, tissue-sparing cannula techniques be adapted in the future?
Oh, the potential is huge.
Right. Could we use this to regenerate other incredibly complex moving parts of the body? I'm thinking about things like the vocal cords or the micromuscles of the hand.
Areas where preserving the blood flow is critical.
Exactly. Places where preserving the existing blood flow and delicate mechanical function isn't just about aesthetics, but a matter of absolute survival and quality of life.
I mean, the tactile mapping we are learning in these soft tissue procedures could very well be the key to navigating the most delicate, critical structures in the human body in the decades to come.
We started today talking about the comfort of an X-ray, the binary visible safety of a broken bone on a glowing screen.
Right.
But what we've discovered is that even in the murky, invisible waters of highly vascular soft tissue, there is a hidden architecture.
It just requires a completely different kind of vision.
A vision built on profound anatomical mastery and the acute sensitivity of the human hand. But the precision is entirely real. Thanks for diving deep with us today.